I'm joined today by Dr. Eric Czemski, who is the Director of Vascular Intervention at Beth Israel Deaconess Medical Center, an institution near and dear to my heart. Welcome, Eric.
Thank you, Sean. Great to be here.
We're coming to you live from ACC here in New Orleans. Great meeting so far.
Absolutely.
So, there's a lot of things we could talk about, Eric. But given your position and history in this field, I'd love to hear a little bit about where you think venous thromboembolism is going and how you became interested generally.
Yeah, that's a great question. I delved into this now a decade ago.
Whoa.
When I was at Mass General as a trainee working under Ken Rosenfield. And every PE that came to the hospital, sick or not sick, symptomatic, not symptomatic, needed an urgent echocardiogram that was done by these hands. And so, it was a great opportunity though to see the whole spectrum of the disease process, even though maybe the echocardiogram didn't make as big a difference for some of the lower risk, asymptomatic patients, but we still got this great understanding of the disease process and the gaps in care. And so fast forward 10 years, I run a vascular intervention program at a sister hospital in Boston, and there's still things that we're learning. So one area that we've done a great job of is coordinated care for PE. One aspect we haven't done a great job is coordinated care for DVT. So we have a lot of people coming in with symptomatic lower extremity DVT that get fragmented care and don't get the same treatment protocols that we do have in place for pulmonary embolism. So this field has grown so much, but I still see this nagging efforts that are necessary to kind of move us forward. And what Inari's done is really help give us the tools to make a difference.
Yeah, I think the way you frame that is brilliant because the MGH model, the one that you were in the forefront for, has been adopted as the way to establish rapid triage for these patients where otherwise, again, they didn't have many treatment options, right? Except for the sickest of the sick would sometimes have a discussion. Now we're entering an era where new technology is emerging with safety profiles that we haven't seen before. So that evolution, I'd love to hear a little bit about, where we were in terms of more lytic-based therapies to where we are now with interventionalists like yourself and what you have available.
Yeah, I look at it from two ways. I look at it from a safety standpoint and efficacy, and then also an accessibility standpoint in terms of how do we provide meaningful care in a coordinated fashion that also doesn't put a burden on the healthcare system. So, starting in the PE realm, lytics were the mainstay. We still use lytics, but we use them at a very smaller fraction than we were 10 years ago. And that's because, again, coordinated care has led us from the high-risk submassive, low-risk submassive to the massives or high-risk PEs to have other options available than giving systemic lytics. And I think that, by having important devices that can improve symptoms rapidly has let us take on higher risk patients for efficacy, and also for having devices that have a good safety profile has let us expand a little bit more to those patients that may be indeterminate in terms of their risk, but meeting enough criteria that we feel interventional-based treatment is appropriate. Same thing's going on in the lower extremity. We've been classically in Boston in particular, anticoagulation. If you fail anticoagulation, you move on to intervention. You move on to intervention. It was cumbersome. We would drip lytics overnight. You need a CCU bed. Sometimes the patient would be laying prone. You have to be in the lab the next day to take them out and do the rest of your treatment. So single session treatment for DVT changed the landscape for especially my practice, where I didn't have a lot of people doing these procedures in the lab. So I had to be available more days than I was available if I didn't have a single session option. And so these things, the evolution both in safety, efficacy, and the type of devices we're using has benefited patients and have allowed us to integrate them into our healthcare system.
Really great perspective, Eric. I'd be remiss to not ask you a bit about intravascular imaging, especially given your expertise and research in the area. So DVT, tell me a bit about how intravascular imaging should and is integrated, and maybe some of the results from some of the research you've done in that regard.
Yeah, we started tackling this issue about 3 years ago, and Sean, we shared that we're both cardiologists in background, and so much of my training on the coronary side was becoming intravascular imaging based. And again, you get to the point in your procedure where I didn't like to end the procedure without my final high-vis run to say I feel really good about this outcome.
Yeah.
And then I looked at the other things I'm practicing, I'm like, we don't do anything like this. It's a lot of guesswork. On the arterial side, you have this small dissection. Is it real or not? I'm just going to leave it and hope for the best. On the venous side is, what is the mechanism of the disease process? We know that there's May-Thurner and external extrinsic compression and some, chronic changes from that, but there's also a lot of superimposed thrombotic disease, chronic lower extremity DVT that had contributed to symptoms, and we need a better tool to identify, differentiate, and guide treatment. Mm-hmm. And so, we approached it a couple ways. The first thing we did was, let's just look at the data. Mm-hmm. How has IVUS changed? And we looked at data. We looked at a number of studies. We did a meta-analysis. We saw some really reassuring data saying that IVUS is improving treatment options, therapeutic decision-making, and patient-oriented outcomes, but they were really in limited case control or cohort studies. Mm-hmm. The majority of the data on the kind of NIVL, the non-thrombotic side, came from the video study, which looked at IVUS-guided stenting in the aspect of non-thrombotic disease. But we needed a little bit more decision-making in terms of both thrombotic and non-thrombotic disease. And so we tackled this through an expert consensus. So we did a full expert consensus document where we had interventional radiology, vascular surgery, vascular medicine, interventional cardiology, and we formed two groups, a writing committee and a voting committee. And we saw that it was pretty much unanimous that if you're going to undertake a deep venous intervention for both thrombotic and non-thrombotic reasons, that IVUS is going to help you understand the mechanism of the disease process, guide your treatment decision-making. Is there clot that needs to be removed? Is this stentable area? And then also guide that if you do go with stenting, making that a safe procedure. What's a healthy landing zone? Making sure you get good expansion like we would look for in the coronary space. So it's been a ton of fun, and I've learned a lot going through it. We have a lot to go still, but IVUS in the venous space, especially in the deep venous space, is way more mature than it is even in the coronary space.
Interesting, yeah. I'm glad that you and your collaborators came to a relatively simple conclusion, which is just use it all the time. Because otherwise, it's hard to parse out, is it a NIVL case, is it an occlusion, where should I use it?
Absolutely. Yeah, when we look at the Medicare data for people who undergo deep venous stenting in the U.S., the most dramatic result of this paper, and it was published in JVIR, is that more than 70% of deep venous stenting occurred with IVUS. Mm-hmm. So now it wasn't about how do we make this the standard of care, but it was trying to understand where that other 30% lived and how do we make sure that we're all on the same page of how we do these procedures. And we know we're under a little bit of a watch. We've seen venous stents fail. We've seen, procedurists take things that are off-label and do things in a varied way. And so the goal was really how do we standardize our practices, and this was one approach. So it's really interesting to look at the data, sit back and say, well, how can we make a difference from the ground up, getting some really experts in the field to participate, and hopefully making a change how we do things clinically.
Eric, thank you so much. Really appreciate the time here and also what you're doing to advance the field. So thank you again.
Thank you, Sean. Appreciate it.
Take care.